I'm going to hand the podium over to Dr. Legowitz, and who's going to chair the next session.
Wow, thank you very much to the conference organizers. I'm really excited to be here for the very first inaugural meeting of Sepsis Canada. It's great to see everybody here. What a wonderful agenda ahead of us today and tomorrow. The next session is entitled The Burden of Sepsis, Epidemiology, Pathophysiology, Recognition, and Cost. A mouthful because there's a lot to discuss over the next 5 talks. It gives me a great pleasure to introduce our very first speaker. You've already heard him ask a very meaningful question today, Professor Allan Garland from the University of Manitoba. Dr. Garland is a professor of medicine and community science at Health Sciences Centre in Winnipeg, Manitoba. He's a co-lead of Team 1 of Sepsis Canada. And his research for Sepsis Canada for the team grant focuses on the incidence of sepsis risk factors and outcomes, a tremendously important question, and he'll tell us today about sepsis epidemiology, incidence, and prevalence. Thank you.
Is this supposed to be a laser pointer? It is. Because you can't see it from the middle of the room. Which is the pointer? Oh, okay, you can't press that button. Okay, thank you. So epidemiology is about the health in populations. So it addresses a number of things. It addresses incidence, which is what I'm going to be talking about most today, which is the rate of occurrence of a disorder of new cases per unit time. So for sepsis, the number of new sepsis cases in a year, for instance. Prevalence is the fraction who have it at a given time. This is really mostly relevant for people with chronic diseases, since sepsis isn't really a chronic disease. It has chronic sequelae, but it itself is not chronic. Prevalence and incidence are pretty much the same thing for sepsis. It has to do with distribution and risk factors. Outcomes, the whole range of outcomes. One of the things that a grant that we're putting in later this week looks at, is hoping to get funded to look at well-being amongst long-term sepsis survivors. And disease control is also within the realm of epidemiology. So defining and identifying sepsis is clearly fundamental, but it's not easy, and there's not agreement either. So there is no gold standard. There is no reference test. Okay, it's not a disease like diabetes. Diabetes, there's a test for it. There's characteristics of it. It's not even a final common pathway disorder like the adult respiratory distress syndrome. There is no characteristic clinical finding laboratory or histopathologic test. So what is it if it's not a disease? It's a syndrome. A syndrome is a variable, in this case, highly variable set of signs and symptoms. About the only thing everybody agrees about with respect to sepsis is the original conception that it is infection that results in acute organ dysfunction. So you saw some slides from this in the last talk. The Global Burden of Disease study from 2017 said that there were 49 million cases a year in the world. Now, the age standardized incidence, this is an incidence example, so of every 1,000 people in the world, 6.8 of them, so 0.68% of them, each year have sepsis. That's a rate, that's an incidence. And interestingly enough, females outnumber males, will have a higher rate. That equated to 11 million deaths, which remarkably is 20% of all worldwide deaths. As you also heard, a diagram of the world showed that low, middle, and middle income countries have the majority of cases. And it's especially prevalent in the youngest people. There's a second smaller peak over age 65. About 50% of all sepsis cases, per this study by Rudd, occur in neonates and young children, and again, mainly in poor countries. And that relates to the fact that diarrheal infectious disorders like cholera are leading causes, not so much in the first world, but in poorer countries, it's very important. Now, this study, and I'll contrast this with some other data I'll show you later, shows that from 1990 to 2017, the incidence fell by 37%, and mortality fell even greater. But this leads to an issue that I'm going to be talking about for most of this lecture, and that is the methodology. I'm not expecting you to read this or really to absorb the methodology of the Global Burden of Disease study. But these studies looking at populations, large groups, either regional groups, regionally restricted geographically, or provincially, or nationally, these all depend on the availability of data that speaks to what's going on in the entire population. And there is rarely direct information of high enough quality to feel confident in our numbers, as I will show you. Okay. So, what is sepsis? Well, there's been 3 different consensus definitions starting in 1991. That itself tells us that we're not exactly sure what sepsis is. The sepsis 3 definition, which is the most recent one, says it's a life-threatening organ dysfunction caused by overly exuberant, dysregulated is the word they use, host response to infection. This is important, and it's often overlooked, even by sepsis researchers. So, this refers to a revving up of the immune system that damages distant organs. Okay? As I said, as I promised you, here's a reference that said that up to 40% of patients treated with infection and thought to have infection in the intensive care unit setting don't have infection when you look at them in an autopsy where you can actually look inside them. In addition, having an infection and having organ dysfunction doesn't mean that the organ dysfunction is due to infection. There's other possibilities. So for instance, if you have pneumonia, which is bacterial pneumonia, bacteria in your lungs, in the alveoli of your lungs, well, that causes local inflammation, and which is pus. So it is certainly possible that the lung dysfunction from some pneumonias, maybe most pneumonias, is not due to overly exuberant immune response, but is it due to pus-filled alveoli? Is that sepsis? It's not clear. In addition, you can have a urinary tract infection. Oh, yes, you have lung dysfunction because you have pulmonary edema for congestive heart failure. Well, that's true, you have infection. It's true that you have organ dysfunction, but they're not related to each other. Yet some of the methods, in fact, the most common method for identifying the presence of sepsis is that you have an infection and you have an organ failure. And saying that they're related to each other is much, much harder. These approaches are required to calculate the incidence. If we want to know the global burden or the local burden of infection, we need to have this kind of information. There are currently 2 population-based methods, and mostly the data comes from high-income countries. So even these 2 methods, as imperfect as they are, really haven't been applied in poorer countries. They are methods that are, again, to do population health, we need information from large populations, either regional or provincial or national. So there's the code-based approach and the electronic medical record-based approach. I'm going to talk about them each. The code-based approach uses hospital abstracts. We are very lucky in Canada to have great hospital abstract data at the national level, except Quebec, called the Discharge Abstract Database. So there's, if you've worked in hospitals, you know there's a medical records department. Usually it's in the basement. There's an army of what I call chart police. And what they do is they go through the written or the electronically written charts and they abstract in a standardized way the information, the diagnoses, the ones they came in with, the ones they developed, et cetera, et cetera. How do they do this? They're not doctors. They are coders. They read what we write and they believe what we write. Okay? So is it perfect? Far from perfect. So in addition, there is the discharge abstract database, which I'll call the DAD, also contains information on procedures that are performed. For instance, intubation and mechanical ventilation is a procedure that helps us identify the presence of respiratory failure. And that uses the Canadian Classification of Interventions, the CCI. Okay. Now, what codes do we use? Well, the explicit codes, there's a code for septic shock, there's a code for severe sepsis, and there's specific causes of sepsis. So AO2.1 is salmonella sepsis. Those are the explicit codes, the ones that have sepsis in the name. Or implicit codes, which is a code for infection, keep pushing the wrong one, plus a code for acute organ dysfunction. Okay? The problem is these data are extracted by coders and they're limited by what the doctors write. Okay? The accuracy of the codes vary, and surprisingly, so for diagnosis codes, there are over 16,000 ICD-10 codes. Okay? Over 16,000. And many of them have never been validated. How frequently are they right? So doctors write something. Does that mean it's gospel? No, far from it. So for many of these codes, nobody really knows in Canada or anywhere how accurate they are. We do know for some important codes. We know about the accuracy by comparison with manual chart review for strokes, for heart attacks, for some infections, but not for most of the 16,000 codes, of which about 1,300 of them are for infection. Okay? In addition, there's no assurance that if you have an infection and an organ dysfunction, that the organ dysfunction is due to the infection. There's lots of different algorithms. Okay, and we in Team 1 of the Sepsis Network are working to optimize those algorithms. There's different coding systems. Some use ICD-10, some use ICD-9, and ICD-11 is coming pretty soon. Okay, there's different sepsis definitions. There's different codes used, and these different definitions, or I'll call them algorithms. One from this column of infections and one from this column of organ dysfunctions, they have different performance. And performance against what? Performance against some sort of manual chart review evaluation, which, by the way, is imperfect. Okay. So the electronic medical-based systems, methods or algorithms use data from EMRs. The most common one and the first one and the most well-studied one is the Center for Disease Control's ASE, Adult Sepsis Episode Definition. So you have to meet a criteria for both a presumed infection and an organ failure. The presumed infection is that you had a blood culture performed, not that it was positive, just performed, and that you had at least one antimicrobial started within a certain number of days from the blood culture and given for at least 4 days or until you die. The organ failure, there's specific criteria for each of these 6 organs. 1, 2, 3, 4, 5, 6. Really, lactatus should be part of hypoperfusion, but it's a separate criterion. Okay? Okay, so this is the definition. So it doesn't use diagnoses that somebody wrote down. It uses this information from electronic medical records. Okay, so what do we get? These are incidence rates per 1,000 people per year, okay? So yearly incidence rates per 1,000 people. And it's based on hospitalizations, since we know nothing about people who might have sepsis who never get to the hospital. You can die in your house and have had sepsis, we'll never know. So this is just based on hospitalizations. And you see that the numbers vary quite a bit. I want to point out a few of these. These are all based on, this is based on adults, except where I say otherwise. This used all ages and this used all ages. And you see that the numbers vary a lot. Now, maybe this is real. Some of it's in different countries, in different parts of different countries, and they use different algorithms, okay? But a few things I want to point out. These guys tested 4 different algorithms in the exact same patient data. And you see that this indicates that the incidence of 3 to 10, a 3-fold difference in incidence, depending on which group of codes you use, shows that which algorithm you use matters. This one's really interesting to me too, because this is a systematic review and meta-analysis using a wide range of algorithms, which they then meta-analyzed. But this shows that based on hospitalizations, it was 2.8 per 1,000 per year. This is all people admitted to hospital. But based on ICU admission only, it was only a quarter of that or less, which indicates that at least by the coding algorithm approach, 80% of all sepsis, or of all people who have a code for an infection and a code for an organ failure, 80% of those never see the ICU. I'll talk about that more in a minute. Now, there's very little data using EMR-based approach. There's only these two, one from the US and one from Hong Kong. And interestingly enough, for whatever it's worth, these numbers are slightly higher than NEDIS numbers. But you see that these numbers, overall, when you look at this, is this real variation? Or is it variation due to our inability to understand the problem, or different algorithms, et cetera? We've got 3- to 4-fold variation here. I don't know what the truth is. Nobody does. In addition, the performance of these algorithms versus a chart review standard here shows that for the code-based algorithms, let me tell you about sensitivity. Sensitivity is the percentage of people who have, of the people who have the disease, the percentage of people for whom the algorithm identifies them. These low numbers indicate that we miss 50 or more % of the people with sepsis. We just miss them. We fail to identify them. So does that mean that the actual incidence of disease is twice as high as we think? Maybe. Okay? So this is a problem. Let me talk about changes over time. This is instructive as well. So in this study by Chenu Ri, he's done a lot of great work in the US on sepsis. Comparison in 2 US hospitals of all admissions over a 10-year period. He found that the code-based algorithms, the one that use written diagnosis codes, the rates of sepsis were going up, depending on which algorithm you used, 8 to 100% per year over 10 years. And yet when you looked over the same period of time at the same patients using EMR-based electronic medical record-based algorithms, it was either much smaller or no change at all. Okay? The performance of codes also was interesting, because across different hospitals, so he did this in 193 hospitals and calculated the sensitivity of the coding methods in different hospitals. You see that the median was not so great, and the range across the hospitals was huge. Now, is this real? Well, certainly there are hospitals that have lots more sicker people and hospitals that have a lot less sicker people. Urban, rural, all these characteristics. Some of this is probably real. How much? Nobody knows. Okay. But an interesting interpretation of the most important part of this. The code-based definition suggests that the rate's going up, 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 up. And yet the electronic medical-based definition suggests it's not. And most people think that a lot of this, maybe all of this, is due to the fact that coding changes over time. As doctors get more used to using certain codes, especially explicit sepsis-related codes, they use it more. So remember I showed you that study, that international study, which used a completely different methodology, by the way, that I'm not going to go through, found that the incidence is falling. These suggest it's rising, these suggest it's flat. What's the truth? Don't know. Okay, sepsis is a syndrome, not a disease. Defining and identifying it is still evolving, and it's very uncertain. But what everybody agrees about is that sepsis there's a lot of it. It causes a lot of deaths, especially among the very young and poor countries, and especially amongst the youngest and older people. What's happening to incidence over time? I have no idea. It's almost certainly true that our incidence numbers are underestimating the truth. And here's why. I already told you about the number one cause. That low sensitivity of both algorithms means that there's a lot of false negatives. People with sepsis we're not identifying from our methods. We don't even know how many don't make it to hospitals, either in poor countries or in remote areas. Manitoba, where I come from, is a huge province. Way the hell up there, it can take 6 hours to get to somebody after you fly your plane in. okay? And so are people dying before they even make it to hospital and therefore not being included in any of these databases? Probably. I want to talk about mild sepsis. Milder organ dysfunction caused by regulated host response to infection. What do I mean by mild? Well, the Sepsis 3 the Sepsis 3 clinical definition says that we need a certain amount of organ dysfunction. And although I won't go over what it means we measure it by the change in the SOFA score. You need a SOFA score change of at least 2 points. You're telling me my time is up? Okay, this is my second to last slide. But mild sepsis certainly exists. Why wouldn't it? It may include most of the sepsis on the wards. It may include an unknown amount of sepsis that never admitted to hospital. And much less work has been done on pediatric and neonatal sepsis. Okay, so is severe COVID-19 sepsis? Don't know. It's unclear. Or is it just pus-filled alveoli? Or is it some combination? This is a big question. If all severe COVID-19 is sepsis, then the sepsis rate's gone up a lot in the last 3 years. If not, I don't know. There is ongoing work by Team 1, the team that Kednapa Tavorn and I lead. Aim 1 is to fine-tune administrative data definitions of sepsis, and same for EMR definitions. And then as a nice segue to our next speaker, Aim 3 is being led by Na Lee, who's going to be your next speaker, talking about a completely different approach. And if you're interested, I can answer your questions offline because I'm told that my time is up. So that's it. Do we have time for a question or two? Are there any questions? Questions? Thoughts? Cool. Okay, Na.